to have been born when I started doing critical care. So we're going to talk a little bit about that. I have nothing to disclose because I don't own any stock in sedation. But what we're going to talk about is we're going to talk about the changes in how we actually sedate our patients in the ICU and how we care for them, and what we've done over the past 25 to 30 years, why we did what we did, why we do what we do now, and why I see that there's going to be some changes in the very, very near future for it. And in talking about how these changes occur, why they occurred, I'll explain to you some of the medical complications and the issues that patients were developing and why we had to make the changes. And then we're going to talk about a couple of older medications that those of you that have been in the ICU with us recently have seen us using for things that they were never truly intended, but actually worked a little bit better as a sedative than they did for what they were actually created for. So we're going to talk about the past, the present, and the future when it comes to sedation and analgesia in the critically ill or injured patient. Now, when we talk about the distant past, I can honestly say that this is a young Dr. Mills, and when he was practicing critical care back in the old days, and the patient needed some sort of anesthetic, basically you just put a piece of wood in their mouth, told them to bite down, and the procedure began from there. As we move a little bit closer to the present, we go to the Wild West, these guys had some really good stuff. And basically this was mixed with alcohol, cannabis, chloroform, and morphine. And I was supposed to give these grand rounds 2 weeks ago, but basically I think I coughed up most of my left lingula, and I wish I would have had some of this stuff 2 weeks ago. And as we move a little bit closer, we move into the chloroform era, where these guys were actually using it for anesthesia as opposed to out on the street for other particular reasons. But where is our past? Where did we start? Well, I can say that when I started critical care in the late 1980s, early 1990s, one of the things that we were doing back then is when it came to sedation, we were using GABA receptor agonists, period. That's what we utilized. Patients came into the ICU for one reason or another, and they received a GABA. And what we use is we used benzos. It's very, very simple. Patients that came into the emergency department that needed procedural sedation got midazolam or Versed. Patients that came into the ICU that needed a sedative got lorazepam or Ativan. And if patients came in via EMS for either seizure activity or musculoskeletal issues, they got some Valium. And those are the sedatives that we use. That's what we had, and that's what we used. The problem with these was that excessive use of it, you gave higher dosages for prolonged periods of time for these GABAs, ended up with decreased level of consciousness. Well, you would think to yourself, well, that's a negative, but we didn't think that way. We thought, aha, the whole idea of sedating our patient was to knock their level of consciousness down, so therefore we used these agents, we used them higher dosages, and we used them for prolonged periods of time. The problem that we weren't seeing at the time, when we look at it retrospectively now, we look at it and we saw that by utilizing these continuously and at higher dosages, that patients remained on the ventilators for a lot longer time than we really intended. By leaving them on the vent for longer periods of time, we had longer ICU stays, longer hospital stays, and all the complications related to that, whether it be infectious, whether it be musculoskeletal, or whether it be delirium. We had all of those issues. And with the benzos, we had significant issues with withdrawal. And as we started to wean these agents, it was not uncommon that 2 or 3 days later, they may be off their Ativan drip, but they still haven't moved. They still haven't started breathing because all of it built up in their adipose tissue, and we weren't able to get them off. The problem also came in that when patients we did wean them, they started having withdrawal symptoms. And at that particular point in time, all we had as a drug of choice for patients who were having benzo withdrawals was what? Benzos. So we gave them more benzos, and it was a vicious cycle. But at the time, that was standard of care because that's all we had. Now, one of the things about GABA receptors that you have to also understand is that they don't have anything for analgesia. So we had to, in addition to what we were doing with the pain, with the sedation, we had to give something for pain, so we used opioids. So when you gave opioids in addition to the GABA receptors, then you had kind of another adjunct for sedation. And they built on each other. We ended up with patients who ended up basically, if they could flick a toe, we were like, oh, the patient moved, we need to give them something else. And half the time, we ended up giving them a paralytic on top of all of this. So life in the late 80s or early 90s was kind of weird. It was kind of different when we were going through it at the time, standard of care, didn't really think much about it. I mean, this is what we had, this is what we used, this is what I was trained with, and we really didn't see anything wrong with it. But as we started seeing some of the negatives, we started thinking, is this really maybe the best way to do it? And like I said, the three agents we had were diazepam, which is Valium, lorazepam, which is Ativan, and midazolam, which is Versed. And each of them have their own side effects. And one of the reasons why we didn't use Valium for much of anything is their half-life. I mean, their half-life was up to 120 hours. If you think we had issues with Ativan, try using continuous infusion Valium and expecting a patient to wake up that same month. It was pretty bad at that particular point in time. So, but, like I said, that was standard of care. So we wandered around, what's your patient on? Oh, they're on Ativan. And we just, and again, didn't think about it twice. But then we started seeing that, it's kind of one of those things that we'd like our patients to wake up this particular rotation. We don't want to hand everybody off to the guy coming on next and saying, yeah, their pneumonia, their ARDS, and their sepsis is all resolved. We're just waiting for them to wake up. Oh, how long have you been waiting? Well, based on the calendar, about 3 weeks. So there had to be something better. And in the mid-1990s, propofol came out. And everybody started talking about that drug, that milk drug. And it was initially used as a general anesthetic. It was used as an induction agent by our friends in the operating room. And as a good ICU doctor across the board, what do we typically do? Is we usually look around and see what other people are using, and then we steal them. We bring it into the ICU and we use it one way or another. And what we found that at lower dosages, that propofol worked great as a sedative hypnotic. It too is a GABA receptor agonist. It had no analgesic properties, so we had to add an opioid to it. But the beauty of it is when we turned it off, it went away a lot quicker than the benzos did. So we were pretty happy with it. Problems with it is that it does cause hypotension with induction. My recommendation has always been, what's your patient's volume status? If they're hypovolemic, they're going to bottom out their pressure. If they're euvolemic or hypervolemic, they should do fine with that. It does cause respiratory depression or apnea. Well, we're using it for patients on a ventilator, so we really didn't care. We thought that was fine. It can cause some problems with dysrhythmia, so you've got to be careful with how much you're using and making sure the patient's electrolytes are okay. And then propofol infusion syndrome, which we'll talk about a little bit more in a few minutes. Now, like I said, we use propofol, and when I first put this up there, I was kind of like, that's kind of funny, haha. One thing I will say, and as a quick aside, it's not really a big issue for our particular department, but we've all got friends in other departments, and in several of these departments, we have friends that have access to this particular agent. This is the #1 addicting drug that medical professionals use. It's quick, it's easy to get, it's not kept track of in any sort of way, and we're seeing way too many of our colleagues overdose on this. So if you've got a friend that you're worried about, tell somebody, especially you young guys out there. I've seen too many people lately that we're losing because of it. So initially the cartoon was supposed to be funny, but the more I started thinking about it, the more I thought this was a good opportunity just to warn y'all. 85% of medical overdoses, IV, are due to propofol. So keep that in mind. What opioid did we use? We used fentanyl. Fentanyl was awesome. We gave it to everybody. It's a synthetic opioid derivative of meperidine. It's short-acting, quick onset. You can use it as a PRN, or you can use it as a continuous infusion. And it was pretty common that you would have a patient either on a benzo, a patient on propofol, and they'd be on 200-300 mics per hour of fentanyl. It worked great. Like I said, we use it all the time. It didn't accumulate in renal failure. It didn't really cause problems like morphine does with histamine release unless you're using it in really high doses for really prolonged periods of time. Otherwise, it worked in conjunction with whatever sedative we were using and kind of increased the effects from there. And people did great with it. But one of the things that I found really interesting is that, as I've done this for years and years and years, is to talk to different nurses in different ICUs who work different shifts, because everybody has a different opinion. This study by Weiner and their group took a look at patients that were on a vent in both the med and surgical ICUs and the different agents that were being utilized. And every 4 hours, the nurses were to assess their patients and determine whether or not the patient was properly sedated, undersedated, or oversedated, and whether they needed redosing or adjustment of the dosing of whatever sedative agent they were using, and or if they needed any sort of opioid analgesic to go with that. They used what was called the MSAT, which is the Minnesota Sedation Assessment Tool. And basically what it is that the nurse walks over to the patient's right shoulder and observes them. Are their eyes open? Do they track? If their eyes don't open, call their name, tell them to open their eyes. Do they do it or not? If they don't do it, they're told to shake their right shoulder and go, hey, open your eyes. See what they do. And then just kind of go and they look at the motor scale and they look at the arousal scale of each of their patients, and they gave them a number. And based on that, they were able to assess adequate, under, or over sedation, and whether the patient needs more drug. And based on that, they look at the risk of over-sedation and the risk of under-sedation, whether they use continuous bolus of either both benzos, the opioid, and propofol. What was really interesting to me is that in over 18,000 4-hour intervals, 85% of them were felt to need to have a sedative. And when they asked the nurses whether the patient's sedation was adequate, 83% of them said they had adequate sedation. 14% said they were undersedated, and 3% said they were oversedated. When they went back and they looked at their MSAT numbers and actually delved down into this, 32% of these patients were actually unarousable, 21% had no spontaneous motor activity, which meant that these guys were all totally oversedated. But again, think about they were looking at patients back, where standard of care was to knock patients down, where you didn't want them moving, you didn't want them interacting. It was felt best that the patient was completely sedated at the time. They said that daytime caregivers thought that oversedation was more frequent than nighttime caregivers, which we joke about all the time in the ICU, is that when you're trying to wean a patient from sedation, it ain't going to happen at night. The nighttime nurses are always going to keep your patients down because they want them asleep, because they want it quiet, where during the day they tend to wean them more. So it was kind of, to me, interesting to see, especially the part where they're like, oh yeah, they're fine, but you're looking at 53% of them that weren't even moving. But again, that was standard of care at that particular point in time. And that's exactly what we wanted. Sedated, intubated, weaned, zero. Nighttime nursing staff. So, and if you look at patients across the country in the U.S. during the same timeline, looking at late 90s to early 2000s, what drugs were being used, propofol, the benzos, you break the benzos down again to midazolam and lorazepam, and you look at the characteristics of over 58,000 patients in this study, they're all pretty similar. And what they found was that early on, twice as many patients that were on mechanical ventilation were on propofol. But as our timeline, as the patients stayed on the vent, more and more people were weaned from propofol, and your number of benzos went up slightly, which is still kind of interesting because we're starting to look at the early 20th century, 21st century, where we know that it may not be the best thing to use some of these drugs and keep people so sedated. And then right down here, you see the emergence of a new drug called dexmedetomidine, which is just starting to make its play. And it also depended upon where you practiced. If you practiced in the urban area, you know, they used a lot less sedation than in the rural area. Be careful of those M-towns, man. They're going to put you down if you come in their ICU. But if you look at the academic centers were very, very high as well in keeping patients sedated. And across the board down here, it just kind of shows you what each individual ICU was doing and what they were using. And of interest, you could see that starting in 2001, you saw a rapid increase in the amount of propofol which is being used. But even here, the numbers weren't that high, but they still didn't go down. No matter what we were learning, benzos stayed in the game. People still loved their benzos, and they weren't really changing them. What narcotic did they use across the board? Across the board, it was still fentanyl. Fentanyl is the drug of choice for narcotics in these particular patients. So we knew all this was going on. We knew that what was standard of care, but we knew that things had to change. Because the things that we were seeing, the side effects that we were seeing with the GABAs, things needed to change. The delayed wean from mechanical ventilation and the increased length of stay, the infectious process, including the VAPs that we were seeing, polyneuropathy, propofol infusion syndrome. You were seeing PTSD, and people don't think about that for ICU care, but it's really not uncommon to talk to patients that have been in the ICU for a while, that have been discharged a couple of weeks, couple of months, or even a year or two later. And you come back and talk to them. And the stories that they tell you about some of the dreams that they had and some of the things that they really, really think are real. and some of the symptoms they have. I have a guy that we had on ECMO about 4 years ago. He was on for 32 days. He was on for influenza pneumonia. And even to this day, every couple of weeks to months, I get a message from him. Hey, Dr. Grier, how are you? And I know where that's going because it's not asking me how my puppy is. It's always something. And it will. He'll start out with just simple things. He'll, how's your dog? I'll send him a picture of my pup. He sends me a picture of his. We go back and forth. And eventually there's something that he thought happened back then, or he's just having PTSD. Something is getting him. So PTSD is it's real in these particular patients in the ICU. And then something that we call critical care psychosis or ICU psychosis, which is really known as delirium, has really taken off. It's amazing what we've seen with that. So with all of those reasons, we really started looking at sedative dependence. Now, patients that are on for prolonged periods of time can develop tolerance or dependence. It's simple as that. And then as you start weaning them, you have to start worrying about the withdrawal of each of those particular agents. So there had to be a better way to do what we were doing. We had to shift how we were doing it. Well, the first thing we did is we took away the neuromuscular blockers. We figured out that very, very few patients out there in the world really need to be paralyzed, number one. And if they do need to be paralyzed, it's a specific subset. And they only need to be paralyzed for a very, very short period of time, by meaning giving them a dose of paralytic, letting it wear off, and reassessing, as opposed to just putting them on a continuous infusion and 3 to 7 days later going, well, let's see what's going on here, and weaning it from there. So we knew we had to get rid of that. We knew that delirium was really a big deal, and we know that the benzos and some of the opioids are really big agents that are causing that. So how are we going to fix that? We needed to shift it to delirium-limiting drugs. And the weirdest thing in the world would be, wouldn't it be weird if you could walk in the room, your patient's on the vent, they're on multiple drips for one thing or another, but by calling their name or lightly stimulating them, like shaking their leg or something, they can wake up, interact with you, and work with their caregivers, which was just such a paradigm that, we never even could have thought that was possible 10 or 15 years prior to that. But what we started to think and see is that if you could get patients to wake up quicker and get them off the vent quicker, you could decrease their day in the ICU by 2 days. Same thing was true from sedation. Get them off, get them out of the unit, 2 days. And the Lancet in 2008 actually published that, and by doing this and having patients that are awake, that work with you, that you can get off the vent quicker, you get them out of the ICU 4 days sooner, saving them a total hospital stay of up to 4 days, which 1 is great for the patient, 2, it's good for you because you can get your beds mobile, and 3, it's extremely cost effective. So that was one of the things that we looked at from complications from using a bunch of GABAs. Another thing that we found is that by using a lot of GABA mimetics, especially propofol infusion syndrome. I don't know if any of you have ever seen it. I've had the pleasant experience of recognizing it a couple of times. And patients that are at high risk are patients that are really critically ill. Your septic patients, your ARDS patients, your neurologic or neurosurgical patients from there. Anybody that's on it for more than 48 hours at higher dosages are at risk for propofol infusion syndrome. What do we see? We see EKI, severe metabolic acidosis, rhabdo, and eventual cardiac failure. How do we prevent it? Recognize it. You've got to recognize it, and you've got to limit the amount of propofol that you put your patient on. If you look at the literature says to use it for less than 48 hours and to not use dosages greater than 75 mics per kg per minute. In our ICU, we do not use dosages greater than 50. Simple as that. We do use it for more than 48 hours, but we won't use dosages greater than 50 mics. If you have to have more, you have to add a second agent, or you need to figure out why that patient is requiring so much. I can't tell you how many times I've gone to the 3rd floor and there are patients on 200. And I just start twitching because I actually watched a young patient die from being on a high dose of propofol. And by the time we came on and we saw this kid, I was like, he was going into AKI, his CK was up, his lactate was through the roof, and we couldn't figure out what was going on. And we looked up, and there's the milk hanging in the room, and it was on like 150 mics per kg per minute, And I was just like, I think that's our problem. But by then it was too late. So we limit it to 50. So those of you that rotate MI, and you noticed why we use that dose and why we have a cutoff order that the nurses cannot go any higher. Even if you tell them, oh, it's okay, go ahead, they won't do it. There's a reason for it, and that's why. So when we looked at all of this, we thought that we've got to change what we've been doing. And in 2002, Society of Critical Care Medicine put out guidelines for sedation and analgesia. But the problem is we started learning so much more. Newer agents were coming out. We were seeing a lot more of these quote-unquote complications. And in 2013, SCCM actually put out what's called the PAD guidelines, pain, agitation, and delirium. And it really kind of gave physicians who weren't in the ICU all the time or docs that weren't in academic scenarios the proper way to treat our ICU patients. And what we found is the first thing you do when you look at your patient is, are they in pain? You assess for pain. Because a lot of patients will seem agitated, will seem anxious, and the first thing you think of, oh, we need to give them a sedative. No. Assess your patient. The first thing you should look for is pain. Is my patient experiencing pain? Because if they are, then you treat the pain, the anxiety, the agitation goes away. And there's two ways that we do it. You can use the BPS as a behavioral pain scale, which basically, in the unit, we look at facial expression, upper limb movement, and compliance with mechanical ventilation. Or, in our ICU and in our hospital, we use the CPOT. The CPOT tool is not a measure of pain severity. It doesn't tell you how much pain the patient's in. It just tells you whether there's pain present or not. And by doing the calculations, looking at facial expression, body movements, compliance with the vent, and muscle tension, everything gets a number. If they have a CPOT score greater than 3, it just indicates that the patient has pain and needs to be treated for it. And then you reassess to make sure, see if you were successful. By doing that, you can do away with so many patients that you're just giving sedatives to because they don't need it. All they need is pain control. Number one thing that we give in the ICU for pain is IV opioids. But now that there's some newer agents out there, the non-opioids is IV Tylenol, things such as that you can use instead. You can get away with having to put these folks on all these IV drugs that cause delirium and other factors such as that. Once you've assessed your patient, you've determined whether or not pain is present. If pain is present, you've treated it. If pain is not present, then you move on to, does this patient need a sedative? Are they agitated? And one of the things that we have learned in all these years, and I can honestly say, is that instead of using these high doses and this heavy sedation, we actually go to light sedation now. We lightly sedate our patient to a specific point. And how we measure them is we measure it either using the Richmond Agitation Sedation Score, which is called the RASS. We usually shoot for 0, is what we want everybody to be, alert and calm. But if we are going to sedate them, we want to sedate them to a -2. -2 is light sedation where the patient is asleep, they're calm, but you can go in, call their name, gently twitch them or something like that. They'll wake up, interact with you, and if you leave them alone, they'll fall back asleep in about 10 seconds. You don't want somebody who you can't arouse, and you want anybody that's pulling out every line trying to get out of bed. You want them about a -2. You could also use the sedation agitation scale, and you want your patients to be about a 4, which is calm and cooperative. If you're sedating them, you want them to be about a 3. We use the RASS in our ICUs at this particular institution. And by doing that, we found that, 1, patients are able to work with their caregivers. Their length of stay in the vent, length of stay in the ICU is much, much shorter. And we've decreased the amount of patients that we see that have delirium and the complications related to that. And all of this really came about was because of what we were seeing with delirium. Now, delirium is a new fancy term for ICU psychosis. And for those of you, you will see this on your boards. One of the questions they always ask, what's the definition? It's a disturbance of consciousness, okay? Change in cognition. It happens over a short period of time. So all those things are coming into play for that. And why is it important? It's important because of the morbidity and mortality that this particular disease process can cause. How do we measure it? We do something called the CAM-ICU. It's easy, it's simple, and basically you ask yourself, does my patient have an acute change or a fluctuating change in mental status? Yes or no? The answer is no. Then their CAM-ICU is negative. They don't have delirium. If the answer is yes, go in, see if they're inattentive. Tell them that every time I say the letter A, I want you to squeeze my hand. And then you basically spell out, save a heart. Heart has 2 A's in it in this particular scenario. So therefore, if they have less than 2 errors, they don't have delirium, their CAM's negative. If they have more than 2 errors, then you move on to see if they have altered level of consciousness. If they do, look at their RASS. If their RASS is greater than 0, they're positive, and you kind of got to go from there. It's really easy to do. It takes less than no time to do it. And you can also look for disorganized thinking, and you can ask various questions. These are just the ones he uses. Will a stone float on water? Are there fish in the sea? Does 1 pound weigh more than 2? Can you use a hammer to pound a nail? It's just simple things like that. Hold up 2 fingers, hold up 1 finger. However you want to do it. But by doing a simple assessment, you can figure out who has delirium, who's at risk for delirium, and who doesn't have it from there. So why do we care? Well, we care because, number one, there's a lot of delirium in the ICU that goes unrecognized. When you ask a clinical physician and you say, hey, a quick question for you, do you have delirium in your ICU? Most of them are going to tell you no. No, I don't have delirium in my ICU. My ICU is fine. We don't have delirium. Up to 66% of patients in their ICUs have delirium, go unrecognized. Not necessarily undiagnosed, unrecognized. People just don't recognize it, so therefore they don't try to make the diagnosis. And why do we care? We care for 3 things. 1, patients who develop delirium have a 3-fold increase in mortality than those that don't during their ICU stay. 2, you're going to increase your length of stay. And 3 is the morbidity associated with it. There's significant cognitive dysfunction that occurs in patients that develop delirium. Patients, the best way to put this is give you an example. I had a patient a couple of years ago, came in for a complex surgical procedure, had some complications from it, spent some time in the ICU, developed delirium. We were consulted to help with the delirium. We brought him up, got him through it. It took us about 2 weeks to get him through the delirium, get him back, to get him to a point where he can go to a rehab. The problem is this fellow, nice guy, he was a CFO of a major corporation. A year later, this guy couldn't balance his own checkbook. So he survived his surgery, survived his ICU stay, but he developed delirium. And because of that delirium, he had significant cognitive impairment. So for all those reasons, we want to try to, 1, prevent delirium from occurring, and 2, if it does occur, to treat it and rectify it as quickly as possible so that our patients, 1, don't have the cognitive impairment, 2, don't have the increased length of stay, and 3, don't have the mortality issues that are associated with this particular problem. There's 3 different types of delirium. The first is the one that we all recognize very quickly. It's the hyperactive delirium. It's the old ICU psychosis. It's the guy in bed 14 that's ripping out his Foley, pulling out his lines, jumping out of bed, yelling and screaming. Well, these guys have the best prognosis because we recognize it and we treat it because they're driving us insane. If they're not driving us insane, they're driving our poor nurses insane. So we're going to do something about it. Hypoactive patients are the nice, sweet, kind little patients like Mrs. Smith who's in room 12. These are not real people, guys. Real room numbers, not real people. Quiet. Sleeps, just kind of stares, watches TV, just looks around. And you don't think about delirium in that patient. You just think, oh, she's a sweet, kind little old woman who's not causing any problem. The problem with that is we don't recognize it very often. And then the worst prognosis is the mixed combination. It's a patient that is going to have both of the symptomatology, and that's the most common one that we see in the ICU. The problem with recognizing delirium is we can't figure out the pathophysiology of it. We don't know what causes it. I mean, we know patients that are on certain medications or in certain situations are at higher risk for delirium, but we don't know the pathophys behind it. We don't know if it has something to do with some sort of microthrombi blocking off small vessels in the brain. We don't know if it has something to do with oxygen-free radicals. We don't know if it has something to do with acetylcholine. We know there's something to it, but the research just isn't out there that's showed us point blank which of these particular scenarios is the real cause of patients going into delirium. So how do we treat it? Prevention. The best treatment for delirium is to prevent it. Like I said, recognize who's at risk, recognize what medications, what disease processes, etc., comorbidities that can put patients into delirium and try to prevent it from there. If a patient does develop delirium, one of the things that we will notice is that using an antipsychotic is probably the best way to do it. And the antipsychotic of choice is Haldol. And the reason why it's a good agent is you can use it PO, IM, or IV, and it's unlikely to cause any problems with hemodynamic instability or sedation. If you read the literature tells you to use 1 to 2 milligrams every 2 to 4 hours. In reality, we use 5 to 10 every 1 or 2 hours. And if it controls patients, but then they rapidly go back to their agitated state, you could actually put it in a continuous infusion and run it 5 to 10 milligrams per hour. What you need to monitor is monitor their QTC. Now, everybody's a little bit different. You know, in our ICU, we use a QTC of 500 or less as our cutoff point. Some places use 450, most places use 500, just so you know from that particular standpoint. How do you treat hypoactive delirium? Not really sure. You can use antipsychotics, you can use some stimulants, but nobody's really sure the best way to treat hypoactive delirium from there. Again, the best way to do it is to recognize it. So even though we still want our patients intubated, ventilated, and sedated, we're kind of shifting from having our patients completely out of it to the ability to, yes, they're intubated, they're ventilated, they are on sedation, but they're lightly sedated. They're not deeply sedated, and we can interact with them from there. And that brings us to the present day to what we're actually doing. We've actually shifted from the GABAs to something called alpha-2 agonists. And with the GABAs, they work in the cerebral cortex, causing the symptomatology, which I showed you earlier. But when you look at the alpha-2 agonists work a little bit differently. They work in the locus coeruleus of the brainstem, right up here. And the cool thing about this is that that allows for sedation, but that part of the brainstem doesn't have anything to do with respiratory drive. So therefore, when we put these patients on an alpha-2 agonist, we don't have to worry about respiratory depression in the bulk of our folks. So, you know, folks that are on the ventilator, they can breathe on their own. You can wean them a lot quicker. You can use these agents in patients that don't have a protective airway because it's not going to affect their breathing from there. It works in the dorsal horn of the spinal cord as an analgesic. As a matter of fact, if you look at the studies on this, and some of the studies have shown a decrease of up to 40% of opioid usage in these particular patients to control pain. So it kind of works for both. So even though you may be using an opioid, instead of having it at 200 to 300 mics per hour, you may be just giving 50 mics Q2 hours PRN because it works as both. It decreases tachycardia, but you will see some bradycardia with it. It works great for anti-shivering. It's a vasodilator. It does improve diuresis. All of these things we found with our alpha-2 agonists. And the drug of choice that we use for that is dexmedetomidine. Dexmedetomidine is an alpha-2 agonist. It's an IV medication. Like I said, it's used in our patients for sedation. It doesn't have respiratory depression. It also has the analgesic effect. It sounds like a commercial at this point. The loading dose is 1 mic per kg. You give it over 10 minutes. The only time that you guys should ever use a loading dose of Dex is in a patient that's hypermetabolic, tachycardic, hypertensive, and agitated. Because if you give a loading dose to a patient that's already chilled, it's already on another agent, and you're converting over, you will see bradycardia, you will see hypotension, okay? But only use that loading dose like you've got a drug, drug withdrawal, alcohol withdrawal, severely agitated patient. Yeah, I bolus them all the time, then put them on a continuous infusion. But if you've got a patient in the unit that's already on a propofol infusion or a Versed infusion, and you want to wake them up, start them on somewhere between 0.2 and 0.7 mics per kg per hour from there of the drug, and then wean whatever they're on and kind of bring this one up until you get rid of that one. And you won't see the hypotension. You may see the bradycardia, but as long as they're perfusing, it doesn't matter. And it's very common in our ICU to see patients with heart rates in the 40s and 50s that are on dexmedetomidine. You check a VBG, their venous lactate, their lactate's completely normal. It's okay. Don't panic. Their heart rate gets in the 20s, you probably need to back off a little bit. But 40s and 50s, it's not a big deal. What's the maximum dose? That's kind of one of those questions out there. If you look at the label says 0.2 to 0.7. The literature says 1.4 is the upper limits of normal. Some studies go up to 2. In our ICU, the upper limits of normal is 3. So things that you can see from there. It's metabolized in the liver. It's eliminated via the kidney. And there's something about Dex, which we haven't really figured out yet, that works really, really well in the septic patients. And it may be due to immunomodulation. We're not 100% sure. It does not cause delirium, and therefore, because of that, we found that we use it a lot more in our patients as they're starting to wean and they're coming off of the sedation, they're coming out of their whatever it is that they put them in the ICU, put them on the vent in the first place. And by doing that, the patient's able to work with the nursing staff, work with physical therapy, work with respiratory therapy. You can get them off the vent quicker. They don't have issues with delirium, and therefore their length of stay is a lot shorter. When you talk to your pharmacists, I mean, when we first started doing this, the PharmDs really pushed back. We had a lot of arguments, but what we started showing was that if we can get patients out of the ICU 2 or 3 days quicker without all these complications, all of a sudden the cost-benefit ratio shifted significantly. So we started using it a lot more from that particular standpoint. So that's what we're doing in the present when it comes to sedation. We're using alpha-2 agonists from there. But one of the things that I did mention to you is that Precedex works good in our septic patients. And why is that? Well, we found that there's immunomodulation, there's immunosuppression associated with some of these sedatives and some of these analgesic agents. Just a couple of different things. When you look at the benzos actually have a problem and they impair phagocytosis and T cell function. By doing that, it has problems with monocytes, like I said, phagocytosis, chemotaxis, and it causes an increase in certain infections. And that's both for both the benzos, and actually you can see that with propofol as well. We see something very similar with the opioids in the immune system with immunosuppression. And then when we look at DEX, the studies, and although there's very few of them, one of the things that we have found with DEX is that it doesn't cause immunosuppression. It actually has shown reduced IL-6 production and reduced apoptosis, and actually patients do better with this particular agent in the septic arena than they do with any of the GABA receptor agonists. I can't explain it to you. I don't have the literature behind it, but that's another reason that in the present day we tend to use dexmedetomidine more than we're using any of the GABA mimetics from there. But where are we going? Well, a lot of times, the slides of the future is now, but where we're heading is one of the things that you're going to start seeing more and more of is different agents such as ketamine. I mean, when I first started training, you talked about ketamine. It's like ketamine is only used in children, and the reason for that is because the emergence and the hallucinations that these people have, there's no way we can use this in adults. We started doing it in the emergency department, where for procedural sedation, it was like every now and then we'd use ketamine in a kid, well then we'd use it like in a teenager, and maybe we use it in a young adult. And we started doing that. And in 2011, this particular algorithm came out from the Department of Emergency Medicine, and people looked at it and went, well, it's a good alternative. And you start seeing more and more utilized in emergency departments. Again, we're ICU docs. Not a lot of stuff is created for us, so we go elsewhere to find it. So we started taking a look at Special K, and we found that it works great in patients in status epilepticus. It's now comes right before the use of pentobarbital in our status patients. You can use continuous infusion ketamine for that. So if we can use it for things such as that, why can't we use it for sedation in our adult patients? And there's very few studies out there, but those that are out there are showing that it improves respiratory function, it doesn't impair cardiovascular function, you're not having the neurologic issues that you worry about so much with these emergence, delusions, and hallucinations, but more studies need to be had. But just so you know, you may start seeing IV ketamine used more as a sedative in the ICU because it doesn't cause the delirium, and it gives us something else to choose from other than Precedex from there. And we just actually used it in a patient on ECMO. We had him on both Precedex as well as ketamine for several weeks. Now, that's when we can use IV. One of the things that we started to see too, and I wanted to mention to you, that there are drugs that are created for other things that were now pulled in to the ICU. Never this popular. Our VP of quality wants something. But we used to use for other things like the second generation of antipsychotics. I mean, we're not psychiatrists. Why are we using antipsychotics? Well, what we found is this stuff works great. You can't use it IV. Unfortunately, I really wish somebody would do a study so we can give IV Geodon. And we're not going to give IM meds in the ICU because we don't know how it's going to be absorbed. Whether the patient's going to have slow continuous absorption, no absorption, and in 3 days when they get perfusion, everything you've given them IM or sub-Q will be absorbed. So we don't use it that way. We do it PO. But one of the things that we started doing with the antipsychotics, and we use Geodon in our hospital, is as our patients are starting to come out of whatever it is, put them on the ventilator, and we're starting to wean whatever we have them on IV, whether we have them on a GABA mimetic, or whether we have them on an alpha-2 agonist, is we start them on low-dose Geodon. And although this slide says 10 to 40 PO BID, which is what the literature shows, we actually use somewhere between 20 and 60 Q8. We usually start about 40 Q8 in our patients. We follow our QTs, again, using 500 as our total. And we start them on that, because once you get that started, you can start to control some of their agitation as you wean the IV medication. In addition to that, I'm going to skip over that. In addition to that, you've got your IV meds, you're starting to add some of the atypicals, and you're starting to use a combination of agents. So in addition to having our IV meds, we're starting our antipsychotic, which here, again, is Geodon, because that's what we use. If you need a little low-dose GABA, you can do it for patients that you're worried about seizure activity from our withdrawal patients. They have their little PRN opioids going on. But another thing that we started to look at was when we're using the alpha-2 agonists, and I learned this the hard way, because I had a young patient that I had him on Precedex for a period of time, higher dosages, did great, got him weaned, got him off the Precedex, and within 24 hours, he was tachycardic, hypertensive, agitated, sweating. He was withdrawing. And it's the same thing that you see. Think about it. If you cut off clonidine like that, what do? They have a rebound hypertension. Same thing is true with Precedex. So one of the things that I learned in that particular case is that when I'm getting ready to wean patients that are on Precedex, dexmedetomidine, whatever you want to call it, that have been on for more than 48 hours, I start them on low-dose clonidine. Everybody gets 0.1 Q8. And it's the weirdest thing in that the clonidine knows that it's supposed to act as an alpha-2, not an antihypertensive. These folks don't get hypotensive with this when you start them for this. So I've got them on my Precedex. I've got them on my antipsychotic, my Geodon. I'm starting clonidine, and by doing that, I'm binding my alpha-2 receptors. So therefore, as I'm weaning my dexmedetomidine to off, there's no rebound effect because I've already got my alpha-2s bound, and you go ahead and wean, and the patient stays stable and calm from there. It actually works as a sedative as well as keeping those alpha-2 receptors bound. You can use it PO. You can use it as a patch. There's this particular, I put this article up here because it goes through all the articles related to using clonidine for sedation. So if anybody thinks I'm crazy, it's actually out there. The guys in the Netherlands actually use it IV. I've never used IV clonidine before. It's an interesting concept. I'd be very, very careful in your cardiovascular patients, knowing what it can do to blood pressure, knowing what it can do to heart rate. But they had really, really good results with it. Again, I've never used it, but I wanted to put it out there for you. And in this particular, it's a pilot study, but it shows exactly what we've been doing for like 10 years. You know, it's like, we need to write this up, guys. We've been doing this forever, and it works great for us in combination therapy to get these people off the vent and get them out of the ICU. So the last agent that we've been using is valproate. For those of you guys that have been in the unit with me, you'll notice that when patients start to get a little agitated, if their QTC is up, I put them on valproate, put them on Depakote. Why? I don't know, man. It's an AED, but for some reason it works great for agitation. Start them between 250 and 500 every 8 hours, and you just titrate it. You keep an eye on their LFTs, and it just chills them. So at the end of the day, when you're finished getting your patient weaned off of your continuous infusion sedatives, getting them off the ventilator, a lot of them are going to be on your atypical antipsychotic, your Geodon, they're going to be on low-dose clonidine, they're going to be on valproate. And then over the next 72 hours, just gradually wean them off, okay? One thing to keep in mind, and I didn't include that particular article in this particular talk, is there's one more article that shows that that's a great idea for combination therapy, but people are forgetting and they're sending them home on it, and folks are coming back to clinic 2 or 3 months later, still on all 3 of those drugs. So don't send them home. Make sure that over the next couple days that they're on the floor, make sure that they're weaned. If you're sending them to an LTAC or a nursing home or a rehab, make sure if you are sending them out on these agents that you limit it so that they get weaned off of it and they're not on it in 3 months when they come back to clinic. And the last drug combination that I want to bring up for you, again, older agents coming back in a newer role, is for those of you that have rotated through the emergency department or been in the ER lately, we're using something called ketofol, which is a ketamine propofol combination. And the reason behind that is because for conscious sedation, we use propofol all the time, but by adding a combo, would this work better? And what we've actually found is that you can see here that by using ketofol, your patients are staying in the therapeutic range a lot better than they are with just propofol, and the number of times that you have to repeat dosages to keep your patients sedated for the procedure are a lot less with ketofol than they are with propofol. Again, your concern is going to be respiratory, and we use the Quebec criteria for respiratory events, and what we found with that is that it's not an issue. Your ketofol patients are just as safe. The POKER study actually is the big study comparing propofol and ketofol, and again, it showed right out that there is no significant difference between the two when it comes to respiratory outcomes, and of course that's your primary outcome with any conscious sedation using a propofol base. And your secondary outcomes, of course, is going to be with the ketamine component of it, or do you have the hallucinations, do you have the emergence deliriums and things such as that. And yeah, they were a little bit higher with the ketofol, but nothing of significant clinical significance, and patients did really well from there. Other things that you can do is, if you're interested, I have this particular slide which has all the articles comparing ketamine propofol combo to propofol, if you have any interest in it or not. If you don't, it's included. If not, I don't care. Another thing that can be done, what else can we do to help our patients get better faster? There's a very, very small study that was done, but they used a PCA, and they put Precedex in the PCA and let the patients control the pump. Instead of us doing it for them, they actually let the patients control the pump, and they were able to, to increase it as they needed to. The nurses checked it every 2 hours to make sure that, it wasn't going crazy. And patients actually used less drug, felt better, and actually didn't have much issues when it came to bradycardia. Patients did really well with that. Small study. And then music or headphones. This is something we're starting to see a lot in the literature for ICUs. Is, instead of using medications for sedation and anxiety, why can't we just use medications or noise-canceling headphones? This particular thing, like I said, there's several articles that have come out on it, and they found that patients really, really prefer that as opposed to IV medications, which I thought was kind of cool from there. And based on that, I'll be glad to answer any questions, and I appreciate y'all staying awake for my sedation talk. Thanks, guys. And yeah, they do this in the ICU too. I always tell people if they need something, yell out Dr. Walter's name. Okay.
As we've moved away from the deep sedation, we trended whether or not people have more or less PTSD post ICU stay. My thought was just if they're causing less delirium, but they're also awake for a lot of the often terrible things we're going through.
If you look at the literature has shown there's been a decrease in it, and from a personal experience. I mean, it's usually going to be the sicker patients, your ARDS patients, your severe septic shock folks that are there the longest periods of time. But yeah, I've definitely seen a decrease in the amount of PTSD, about the weird dreams. Patients would come back all the time and just go, man, I had the weirdest dream, and they'd tell you about it, and you just kind of go, no, it's not real. And like with Shane, his biggest thing was, I swear you were under my bed, you were going to jump out and kill me. I said, man, listen, at my age, I can't even bend over to pick over a pen. I can't get underneath the bed. It's just little things, just talking them back down, but not nearly as frequently as he used to because of less of the delirium. Thanks, guys. Have a great day.